Okay. So the first topic that we are going to start is basically from the rash. We have to start. So, okay. Then rash. So we finished our topic at failure to thrive. So failure to thrive, we have already see that all the clinical features, all the investigations you need to do. So since you have to rule out all the clinical and psychological aspects of the disease. So in the children's, you cannot miss the psychological aspects. Maybe something underlying abuse or neglect is going on. So yesterday, when somebody asked about failure to thrive, so we have to report it to CAS or not. So it depends what kind of circumstances is coming that patient with. Like if mother is complaining something and you are suspecting something else, even when you're suspicious of something, you have to tell the CAS. Okay, in the terms of the taking care of the baby, like when you are treating a child specifically, when you are even suspecting, you are not sure, it's good that you are on the safe side, because if you neglect something, then you are also on the side where you have done something which is not on the good doctor side, right? So you will be liable if something bad happened to that particular child. So in the peds, if you are suspicious, you have to report it. Okay. Then comes obesity. Obesity, all these etiologies, risk factors, complications, and management. It's just written here specifically. So we are going to start from the this poison prevention, how you are going to counsel the parents about them, and this rashes. So this is the common pediatric rashes. There is one table here and then one table in the where I think in the it will show up in the bottom list. So we will talk about that. First, there are these rashes. These are very common. So you need to know what are the two types of the rashes. One is diaper rash, and others are like they have generally divided it into two. First is diaper, and then other is basically others dermatitis. So differential is basically irritant contact dermatitis, seborrheic dermatitis, and candidal dermatitis. So now we have to differentiate about these three. Everybody mix up this irritant dermatitis with allergic dermatitis. Here, this one, and then this irritant dermatitis. This irritant dermatitis and this irritant dermatitis is same, but the only difference is basically that is happening at the site where the diaper is, and this is happening anywhere, any part of the body. Okay, so this irritant dermatitis, what happens? Appearance is basically shiny, red macules, patches, no skin folds involvement. So now this thing, no skin fold involvement is basically irritant contact dermatitis. But when the skin folds are involved, this is basically candida. Okay, it is involving the skin folds. Now comes the seborrheic. Seborrheic is basically with yellow, greasy macules, scales. So I would suggest when you are reading these topics, go to Google, take out the pictures, and what you are seeing over there, try to memorize from that. Because if you just memorize it and they show the picture, it's not going to be easy for you. They haven't put any pictures in Toronto notes, so I cannot show you here. But I highly appreciate it if you are reading these topics. Just go to Toronto notes. Just go to Google, see those pictures, and then read the topic. It will be very easy for you. So management is same for everything. First, you have to start with the non-invasive one. What are you going to do is basically giving that Vaseline, giving the moisturizers. Then whatever the suspected thing is, we start with the topical low steroids and then go for the high steroids. So air first is basically, obviously, if it's irritant, then you have to remove that particular thing that is causing that irritation. Sorry. Eliminate direct skin contact with the urine and feces, allow periods of the rest, and then gives the steroid. If everything is already tried and it's not working, then you have to start with the steroid. Then comes the seborrheic. Obviously, you are going to start from the moisturizer, then antifungal and low potency corticosteroids. In candida, you have to start directly from antifungal because you can see this is candida. If you are going to start with the steroid or moisturizer or something, since it's fungal, so antifungal can work properly. Atopic is basically when moisturizing is proper. The problem is moisturizer, right? Baby is not having enough moisturizer of that particular part of the body, so that's why. So classic area is atopic dermatitis. I would highly suggest to go to that dermatology here. Here, dermatology, there is pictures of that atopic dermatitis over there in the Toronto notes. They have shown which folds are involved. So you have to remember those folds of particular age, or which folds are involved in child, which folds are involved in adults, which folds are involved in baby. So you have to know all of these folds specifically, because in each age the folds are different, which ones are involved, which particular part of the body is involved. So what are you going to do is eliminate exacerbation factors, maintain skin hydration, corticosteroids, and topical calcineurin inhibitors. Nummular is basically the round annular erythematous plaques oozing and crusting. Avoid irritant if it identified potential topical steroids and short-term steroids. So I will answer all the questions once I'll finish this one, because I have a lot of topics to cover. So you guys can write down the questions in the chat and we will discuss in the end of the session. Then comes the allergic. Allergic is basically red papules, plaques, vesicles, bulla is formed. So this is basically because of allergy. So you have to take out that particular allergic, and since it's causing a lot of itchiness and irritation, so you have to start with the calamine lotion, and then low potency corticosteroid. So always when you are starting a steroid, always start from low. You are not going to start with a high dose. So you have to mention when you are writing steroid, either you are giving low or either you are giving high potency, low potency. Okay. Irritant contact dermatitis, avoid skin contact. Then dyshydrotic, basically the problem is moisture. So it comes as papulo, those heel cracks and hand and feet. So those things. No, so we start with the corticosteroids, and then we can start with the systemic corticosteroid. Once you have already tried the topicals one and it's not working, now we have to switch on to the systemic one. Then infectious scabies. When scabies is treating, once you are treating the scabies, it's very important, if they ask for the treatment, you are not going to treat the baby. You are not going to treat the particular patient. You have to give the prophylaxis to the whole family. Then your answer will be completed. If you write down permethicillin to the particular patient and you forget about the prophylaxis of the family, your question is not completed or your answer is not completed. So you have to make sure that you are talking about just the same. If you are going to treat STIs, if you treat the particular patient but you didn't treat their partners, then the treatment is not completed. So you have to treat those all particular diseases which can transfer from one person to another without knowingly. So you have to treat the persons and the patient family as well. Just like meningitis, you have to give rifampicin to their family as a prophylaxis as well. So you have to see which one are those particular conditions where you have to treat the family members as well. It is basically polymorphic in web, especially in the hands, very pruritic. So you have to see the pictures. It will help you. Sometimes they don't give you particular characteristics, but on the basis of the pictures, you can see this is scabies, and then you can give the treatment according to that. Permethrin and especially the family as well. Impetigo, so it is honey-colored crystals and bulla formed. So start with antibiotics, fusidine and mupirocin, and then oral antibiotics. Then tinea corporis is basically erythematous plaque and central clearing and scaly borders. So you have to see all of these. It is very easy for you if you see the pictures, then you can differentiate between all the types of rashes. So now coming to the next topic. The next topic is child abuse. These nightmares and night terrors are important as well. One of the very big difference about the nightmares and night terrors is that how I remember is the mares, right? So baby can easily recall it because it is nightmare, so he can recall it. But this night terror is something which is terrifying him, right? So he could not particularly tell what is going on with him, right? So when you wake him up, he will not able to recall it. So they will definitely tell you that the baby is coming, he's crying, he's shouting, is whatsoever. And when they recall it, he is able to recall the dreams or he isn't able to recall the dreams. So on the basis of that, you can tell it is nightmare or it is night terrors. And the treatment is different. If it's nightmares, so you have to do the reassurance that if it's night terrors, you have to rule out. Maybe it's baby is having, particular child is having some problem if it's psychological. Maybe he's getting bullied or maybe he's in depression, having PTSD. So you have to rule out all of those. SIDS. It is very, very, very one of the very important topic, I would say. So definition is basically sudden and unexpected. It is mentioned in the MCC objective as well. So I would recommend go to MCC objective and see it from there as well. Sudden and unexpected death of the child less than 12 months. And this child death happen most occurs at midnight to 8 a.m. So this is thing. Okay. Peak incidence is 2 to 4 months. It is happening. And if one baby is affected by this thing, then it is very high likely chances that his siblings or that particular patient's family might be affected with the same. So risk factor is prematurity, early bed sharing, alcohol use, pregnancy, soft bedding. So you have to remember all these risk factors. Sometimes they just mention smoking, they don't mention anything else. So you need to know that smoking is also one of the problem. Maybe baby sleeping in prone position and poverty. So all of these are the risk factors that can affect the SIDS. Risk of SIDS is basically 5 to 6 times. As I told you, if one part of the one one child is affected, so their siblings could be affected as well. So who have died of SIDS. So bed sharing is one of the problems. So you need to know these risk factors. On the basis of that, you can tell the prevention. If they are mentioning something particularly in the scenario, so you have to write down in the answers when they're asking about prevention. So specifically, those things come first. Obviously, if they're saying that the baby was in the front position and blah blah blah, now the next baby is coming and they want to avoid the particular position, particular SIDS, right? So what are you going to start with your counseling? Obviously, the problem which they encountered first, you are going to tell about the rest of the stuff as well, but you have to remember what comes first. Those things which are already mentioned in the scenario, those things should be counseled first, and then rest of the things should be counseled as well. Okay, so back to sleep, front to play, avoid sharing bed with the infant, avoid tobacco, avoid overheating, overdressing, appropriate pet bedding, and breastfeeding. Pacifiers appear to have a protective effect, but it is very important that do not insert if fall out during sleep. Infant monitors do not reduce incidence. Then this is the adolescent medicine. So you have to remember these heads. Everything is written inside. What are you going to ask and everything. This is important for NAC. This is consent and the close age expectations. This is exceptions. It is basically important for ethics. And one of the very important question of the ethics. You need to know when the consent is started. For the treatment or for the understanding of the patient, there is no legal age in Canada. If the child is 8 years, 9 years, 10 years, and he understands what the consequences of that particular treatment and he wants to not do it, so you are not going to do it. But at the same time, if one of the family member is ready to start the treatment and the baby is okay too, and then father is not agreeing with it, you are to going to treat them until unless the patient is having specifically like it's okay to not treat it. But if that thing is going to affect in the later condition and one of the family member is okay with it, you have to treat that patient. Okay, then comes the consent. This is about the sex age. So about so age of the 16 is the basic the age of the consent is 16, and the youth 16 to 17-year old cannot consent if the partner is in the position of authority. So you need to remember when are they going to give the consent. So a 16 to 17-year old can give consent to anyone. Okay, so he's liable to take have a relationship with anyone, but that particular person should not be in the position of the coach or teacher or somebody who has the authority. Okay, any tutor, anyone who's taking care of that particular person, like care, supporter, or anything like that. So that particular thing is not applied. Like if he's having a problem relationship, like I'm just giving an example, a 16-year-old girl is coming to you and she's having a relationship with 35-year-old, and that person is not his coach, not his any authority, not his trust or anything, then he can have a relationship. Okay, but if that particular 35-year-old man is his coach or his tutor or his caretaker, then she cannot take the relationship with that particular person. Okay, and after 14 to 15, the relation should be less than 5 years. So she could not take the relationship more than 5 years. So a 14-year-old can have a relationship with only person who is above 5 years to his or her age, or below 5 years of his or her age. Same goes for the 15 years. Okay, and then no relationship applies to every person. Okay, so you have to see that same no relationship, like authority relationship. That person should not be the age, that person should not be the teacher, that person should not be the caretaker. So all of these things, especially in the children's, you have to make sure what the scenario is written. If they are mentioning specifically a coach or a teacher, so they want you to tell that family member or that children or whatsoever, not family member, actually that particular person who's coming to you. So you have to tell them this relationship is not liable, and you have to tell that to the CAS. So 12 to 13 can have only relationship with the 2 years. So if a 13-year-old is coming with the relationship having 15-year-old boy from his class, he's totally okay with it, and there is no relationship of authority, trust, or dependency, she can have that relationship. So there is no age of having relationship. Like, it's not like it's particularly need to be started after 18. So she can start relationship at 13, but it should be within those particular grounds which I already mentioned. So half of the police reported sexual offenses are against children and youth. So you have to make sure if she is coming with some sort of vaginal discharge, so you have to rule out maybe some STIs or something going on. Okay. Then this is developmental stages. If you can remember it, I mean, I can never remember it. So if you can remember it, so why not go for it? Then comes child abuse and neglect. Child abuse and neglect is very, very important. This is one of the topic of the pediatrics you cannot miss, or if you can miss it and you are going for the exam, then you are doing something which is very, very wrong. Then child abuse and neglect, an act of the commission and omission by our caregiver. So if somebody, a child is having a physical, sexual, or psychological abuse, so these three things you have to make sure that the baby or the child is not having these three aspects. If let's suppose a family is having a domestic violence and the child is never affected by that domestic violence, and the child is only affected because obviously he is not affected physically, he's not affected sexually, but he is affected by psychological aspect, right? So in that domestic violence, even if the child is not getting any hit or not having any sexual problem, since he is having a psychological aspect, right, still you have to tell the cast. If they particularly mention that in this domestic violence household there is a baby living with it, there's a child living with it, so you have to tell to the cast. That's the first thing that they want you to know. Okay. They want you to write down in the answer that results in the harm to the child or the potential for the harm. Legal duty to the report is upon reasonable grounds to suspect abuse or neglect. Physicians are required by the legislation to contact the CAS. As soon as you find the suspicion, you have to tell it. And duty to report is overrides potential patient confidentiality. Like a woman is coming to you, she said, okay, like you have already confronted her that you hit your baby or you have abused your baby, and now I'm going to tell to the CAS, and she said, no, don't do it, this is my confidentiality, you are not allowed to tell it. You have to tell it. Okay. Physician is protected against liability, so you, even if you are suspicious that you are thinking of it and you are not confirmed, this is the only thing, when you are not confirmed, you have to tell it. Okay. If there are additional reasonable grounds to suspect abuse, neglect, you have to tell to the CAS. Then risk factors might be social isolation, poverty, domestic violence. So in all of these things, abuse, physical illness, postpartum depression, substance abuse, parent family, uh, poor social vocational skills, below average intelligence, and then difficult temperament, disabilities, special needs, and premature. So in all of these things, if the baby is coming with a developmental delay and you find that maybe the baby is not developing because the parents are not taking care of him, maybe the parents are not giving proper food, maybe the parents are neglecting, maybe the parents are drug abusers, or maybe parents are something like that, anything that is mentioned and giving you hint in the scenario, you have to tell to the cast. That is the only thing. Okay. Do not take an abuse history from the child. Obviously you are not going to traumatize the child, so you have to take the history from their personal partners, anybody who is around that. If the partner, sorry, if their parents doesn't want to give the history, you have to ask their teachers or any authority member. Report all the suspicious. Since I said suspicious here, this is the only scenario where you are suspicious and you have to tell the cast. Otherwise you have to make sure, yeah, this is something happening now I'm going to tell. Okay. So this is the only case where you are going to suspicious and you are going to tell. So if this is very high likely case, then you have to hospitalize the baby and then do medical evaluation and average consultation. Physical abuse is basically when the child is getting hit, right? So you have to ask the history, and then if you suspect that the history is not making sense with the child factors, right? Baby is having, or child is having bruises on all over his body, and and the mother is saying, oh, he might have fallen down from somewhere, so that doesn't make sense with the presentation, right? So what are you going to do here is basically you have to tell to the child about you have to tell to the cast before proceeding to anything else, so you are not liable for any kind of problem. Okay. Delay in seeking medical attention that is unexplained by the factors. So all of these things, previous trauma, hospitalization, family history, bleeding problem. But first, if it's coming with the bruises and everything, you always have to rule out maybe he's having osteogenesis imperfecta, these kind of conditions where the baby can have these kind of problems without any trauma or stuff like that. So you have to do out all those conditions as you have to tell the CAS. Okay. Physical conditions not explained, growth parameters, multiple injuries and skin injuries like linear shapes, etc. They do not match, provide history. So then comes the injury location, maybe the bruises, obviously, that cheeks, buttocks, and neck and feet, bruises that do not fit with the described cause. Then fractures like rib, metaphyseal, because it's very unlikely that like a child is having a femur fracture, right? Because unless he falls from something very particular, like from particular height, right? So that kind of things, immersion burn. So you have to go to the Google and see how those pictures look like. This is important, how those pictures of the bruises, how those pictures of the fractures, how those pictures of the burns look like. Altered mental status, baby is having like a child is having like a head injury and poisoning. I'm keep on repeating baby, but it's not baby, it's actually child. Okay. Eyes, retinal hemorrhages, scalp is basically patchy hair loss, and oral is basically frenula for the tear. Head trauma is leading cause of the death in the child, maltreatment. So direct force like acceleration, deceleration, those things. Red herring, then investigations, all of these investigations. So you have to do make sure that his baby, the child is not having osteogenesis imperfecta, he's not having bleeding problem, he's not having other kind of congenital anomalies. That is maybe the hidden agenda of it. So you have to rule out all of those, and all the injuries that should be photographed not by your personal camera. It should not be used by your personal physician's camera. The camera should be used by the police or the hospital, photography preferred. Okay. Then rule out medical cause of the bruising, fractures with the appropriate investigations like blood disorders, rickets, and fracture evidence calcium, magnesium, phosphate, ALP, PTH. So have to rule out all those, maybe rickets, maybe all those things that can present like that way. So you have to rule out all of those. Bruising, all of those, bleeding disorder, von Willebrand factor, factor 8, factor 9, all of this. Maybe any liver problem, transaminase level, that is also causes bruising. Renal problems, maybe he's having edema or stuff like that because of the renal problems. So electrolytes, urine analysis, rural post streptococcal glomerulonephritis. So these things can present like that way. Toxicology, maybe he's had overdose with something. So skeleton survey, this is it. This is thing. The skeleton survey is up to less than 2 years, and selected imaging like having X-ray or something started after 5 years. So what about those who are 3 to 5? So you can still do skeletal survey. Okay. So after 5 years, you started with a particular X-ray of the femur, particular X-ray of the humerus, particular X-ray of particular party, a particular bone. Okay. So up to 5 years, you can do skeletal survey. Skeletal survey involves all of the investigation, treatment, like all of overview, all of the CT scan, all of the MRIs. Okay. Then neuroimaging, CT, MRI, dilated eye. So you have to see if there is any subdural hemorrhage, because maybe babies, that baby shaken syndrome. So that is kind of thing. So you have to rule out all of those problems. Then comes the sexual abuse. Medical assessment of the bruising in suspected child maltreatment causes CPS. So this is the things that are red flags. Always remember red flags of any disease. You cannot miss any. You can miss anything, but you cannot miss the red flags. Bruises. Babies can get bruising, and parents on the presents on the ear, neck, feet. So this is very unlikely having bruises on the neck, having bruises on the ears, having bruises on the feet. So if he's having, so you have to think of maybe he's being tortured, he's being think. So even if you are thinking that way, you have to go for the CAS. Not on the front of the body. What is going to happen with the CAS? CAS is nothing. He's going to come. Sorry, CAS is a society. Those people are going to come and take the history, and if they make sure, yeah, this is okay, this was just a suspicious, they're not going to make you liable or you wasted our time. No, they're just going to come and talk, and then they are going to leave. Okay. So it is not like you have to do like make sure that something is going on, and then you have to report. Not on the front of the body and overlying and large and numerous, clustered and patterned, not fitting with the described causal mechanism, how they are telling and how the features presented. Sexual abuse is basically 2 to 6 years of the peak, 12 to 16 years. Most do not report until adulthood. So you have to rule out obesity. Maybe he's having underlying sexual abuse happened in the childhood, and now he's presenting with maybe like obesity, having depression, and eating too much, IBS, fibromyalgia, all of those things, STI, substance use disorder. So sexual abuse is related to substance use disorder. A lot of people present with the substance use disorder, maybe having PTSD and started using some substance. More likely to experience intimate partner violence and sexual assault in decreasing order. Family members, not relative, known to victims. So most of the time, they are the family members. That is the cause. Then history, you have to ask about the fears, depression, nightmares, withdrawal, and lack of trust, self-esteem, failure, sexually aggressive patterns, and then sexual knowledge and sexual preoccupation. Then physical exam, you have to rule out UTIs, because all the sexual abuse can present with the UTIs, pregnancy, STI, vaginitis, and vaginal bleeding, pain, injury, and everything. So you have to do anogenital, no instrumentation. This is important. Instrumentation not required for the anogenital tract. So you cannot do instrumentation to somebody who is prepubertal, right? So it is not allowed. Contraindicated. Speculum is contraindicated. Most victims have normal anogenital exam and do not cannot rule out sexual abuse. If the anogenital tract is normal, so you cannot since say that, oh, she's not sexual abuse. You still have to rule out other things. Investigations, you have to do sexual assault kit in within 24 hours. This is basically done by the those sexual abuse working society. But if still he's coming in the emergency, you have to do this. Rule out STIs, UTI, pregnancy, rule out other injuries, and rule out drug and alcohol screen. Maybe he was given liquid G, all those rape drugs. Neglect is basically omission and the care of the parents because they are not giving proper food and everything. So you have to start with the asking about the history, then physical exam, head to toe, dental care, emotional, and then investigation. Blood test to rule out medical conditions or the nutritional conditions like thrombocytopenia and coagulopathy. You cannot just directly label it. So, always make sure you rule out other conditions that can present like that way. Then comes the congenital. So this is all the pathology. I'm not going too much into detail with it. So this table, if you can remember this one, all of these things are written here. So left to right shunt, obstructive, right to left shunt, others. So these all are the conditions that can present with these things. So characteristics of the chest X-ray, they can be presented like that way. ASD, uh, I would say go to MCC objectives and see which one of the congenital heart disease are more common and do those ones. Just don't waste time on doing like specifically. I think they are mentioned which congenital heart disease you need to do, and do only those. Not do everything because you don't have to know every particular thing. Since you are not a pediatrics, you are a family physician, so you are not going to treat that particular patient coming to the congenital heart disease. Even in anywhere in the country, I'm not sure what other countries practice, but here it's not like that. You have to stay in your limits. Like you have to know that where you have to refer that particular patient to the pediatrics. So arterial septal defect, if that particular patient, you need to know the clinical features. If somebody is coming with the asymptomatic or maybe having a pulmonary outflow murmur, right? So you know, okay, this is ASD. You do little bit of investigation like X-rays, chest X-ray, ECG, or echo. Now you are not going to start opening the heart and start treating it, right? You are going to refer to the pediatrics or maybe cardiologist. That particular person is going to start the treatment. So all you need to know is the investigation and then clinical features. So you, on the basis of that, you can make at least make the diagnosis. Okay, and if they asked about the diagnosis, what are the next investigation, at least you can do investigations, right? So all of the congenital heart disease, 3 investigations are done: ECG, chest X-ray, and echo. Okay, and then management, in some places it says do management, and in some places they don't say do management. So it's totally up to you. If you can remember, go for it. Then the ventricular septal defect, you need to know which kind of murmur is presented here, systolic or holosystolic murmur. And I think it's very nicely written. If you go to the pediatric book, that is, I guess, I'm not sure. It's used in Pakistan. I'm not sure anywhere else if it's used or not. It's very nicely written over there, which murmurs are present in which heart disease. So if you can read it from there, it will be very easy for you. Delayed growth and exercise tolerance and recurrent UR, upper respiratory tract or asthma episodes, and physical exam, holosystolic murmur on the left lower sternal border, then ECG, echo, and chest X-ray. It is done investigations. Same goes for the PDA. PD represents as the machinery murmur, so you need to know the machinery murmur and all the investigations, same investigations, so you need to know these investigations. And then what is the treatment? Indomethacin. Same goes for the obstructive coarctation of aorta and aortic stenosis. So I want to focus on this one, teratology of Fallot. So teratology of Fallot is basically pathophysiology. I'm not going so detail in it. So clinical features. Clinical features basically TET spells. TET spells like crying, exercise. It can present and right to left, irritability, crying, and deep breathing, rapid. And then that particular patient is saying that squat position is helping, right? So they can present all of those features. On the basis of that, you can say, yeah, this is teratology of Fallot. They will present with the TET spells. So all of these things, you are going to start with the history, physical examination, then do investigations, and then the treatment. How I remember is MOPS, morphine sulfate, oxygen, P for position, and S for saline, like fluid. So if you can remember that way, if you have already remembered oxygen, niche as position, fluid bolus, morphine sulfate, propranolol, and phenylephrine, it's good to, right? So if you cannot, like, MOPS is a very good thing. Morphine, oxygen, P for position, P for propranolol, P for phenylephrine, and S for saline. So it's a very good, I think, remembering thing. Then treatment is surgical repair at 4 to 6 months of the age. So you have to remember all of these: 1, 2, 3, 4, and 5 and 6. These 6 things in the management. In the other one, you can see all of those are basically treatment, all the investigations and the treatment, everything is mentioned here. So if you can read it and remember, it's kind of easy. Abstinent anomaly, it is basically linked with the lithium, right? If a mother is taking lithium while pregnant, so this abstinent anomaly can be the cause. So there is all etiology and pathology is written. Mostly it is lithium. What is the treatment? Consider closure of the tricuspid valve, aortopulmonary shunt, and older children's tricuspid repair. Then the features of the hypoplastic heart disease. Congestive heart disease is just like the same how the old like big like adults are being treated. So four features, four tachys, sorry, two tachys and two Magalis. The treatment is same: sitting up, oxygen, all those LM and OP. These dysrhythmias you have to do from the emergency. If you do it from there, it will be easy for you to do it here. So the murmur, it is important you know which one is innocent murmur and which one is pathological murmur. Sometimes an MCQs or anything that comes from here. So you need to know innocent is basically asymptomatic, systolic, ejection murmur less than 3, psychological, none, and murmur. If this is not applied, all if this is pathological. So if you can remember innocent one, pathological will be easy. If you can remember pathological and innocent will be easy. So you need to remember at least one of the both. So these ones, which one is linked with the which differential diagnosis? Okay. Okay, I think I will stop it here so we can discuss about your questions.